Hello, my name is Ahmed Sallam. I'm a retinal surgeon from the UK. I'd like to present a study from the UK National Ophthalmology Database about the outcome of primary surgery for Rhegmatogenous retinal detachment. I would like to acknowledge the work of the co-authors, Mr. Paul Donaghy, who's a medical statistician, and my consultant colleague, Dr. Rob Johnston. There is variation in the reattachment rates of published series of primary surgery for Rhegmatogenous retinal detachment. This study is one of the pivotal studies published in 2002, which is the National UK Audit of Primary Retinal Detachment, and showed a primary success rate of 83% when surgery was done by a specialist consultant and 81% when surgery was done by a fellow. Scleral buckling versus primary vitrectomy in Rhegmatogenous retinal detachment is another important study published in 2007, and the success rate in this series was 72%. Interestingly, scleral buckle had more success rate in phakic eyes compared to vitrectomy, but the opposite was true in pseudophakic eyes. Our study was a retrospective study using electronic medical records. We included patients with primary Rhegmatogenous retinal detachment operated between December 2002 and November 2010. We defined primary success as no subsequent retinal flattening procedure after the first retinal detachment operation. Our study included 14 UK centres, 76 surgeons, 3,403 eyes, and the median age of the patients was 60.8 years. There was a slight male to female preponderance. Regarding the primary retinal detachment operation, general anesthetic was used in about 32% of cases, local anesthetic in 51%, and in about 17% there was no accurate recording of the type of anesthesia used. Consultants operated on about 58% of cases, while fellows operated on about 26%. Regarding surgery classification, primary vitrectomy was the most used procedure, followed by combined vitrectomy buccal, and buccal surgery only was used in about 8.7% of cases. The primary success rate in this series was about 87%. About 13% of eyes failed primary surgery and required more than one retinal detachment operation. Further analysis of eyes that failed primary surgery showed that in relation to surgery type, both primary vitrectomy and buccal surgery had nearly similar failure rates. Combined primary vitrectomy and buccal surgery was not associated with lower failure rate compared to primary vitrectomy alone. In relation to surgeon grade, consultants had lower failure rates compared to vitreoretinal fellows. This is a funnel plot for nearly all surgeons, showing percentage of operation complicated by failure versus number of surgery performed by each surgeon. The dotted line is the mean failure rate, which is 13% in this series. This study has several limitations, which include the retrospective design as well as the unadjustment for case mix in this study. To summarize, this study included 3,403 eyes that underwent primary retinal detachment surgery. Primary success rate was 86.9%. Failures were slightly lower for consultant specialists than trainees. Combined vitrectomy and buccal surgery was not associated with increased success rate compared to vitrectomy alone surgery. One final point which we found interesting is intersurgeon variation and failure rate. If you look at this curve, it doesn't appear that there's much variation between surgeons who performed 50 cases, for example, and high volume surgeons. The failure rate is not much different. This is completely different from other types of surgery where you expect to have lower failure rates if you're a high volume surgeon. This is a curve of posterior capsule rupture in relation to phacoemulsification, and it shows that the more you perform, the less failure rate you're likely to have. In conclusion, we feel that the biology of retinal detachment seems to dictate a significant failure rate, even in best hands. Unlike other branches of surgery, increased volume does not consistently lead to reduced failure rates once you've mastered the techniques of surgery. Hence, in addition to maintaining excellent standards, we need new therapies to avoid failure. This is an acknowledgement for all UK centres who contribute to the National Ophthalmology Database, and I would like to thank all surgeons for this. And finally, I would like to thank you very much for your attention.